So with that, I will introduce our first speaker. We're privileged today to have Dr. Nicole Lurie. Currently, Dr. Lurie serves as a strategic advisor to the CEO of the Coalition for Epidemic Preparedness Initiatives. She is also a senior lecturer at Harvard Medical School and on the research faculty at Massachusetts General Hospital. In addition, she's a professor of medicine at George Washington University School of Medicine and continues to practice clinical medicine in a community clinic in Washington, D.C. Prior to these roles, she served an 8-year term as the Assistant Secretary for Preparedness and Response at the Department of Health and Human Services, and she led the response to numerous infectious, natural, and man-made disasters there. She was also responsible for many innovations in emergency preparedness and response. During that period of time, she chaired the Public Health Emergency Medical Countermeasures Enterprise, a government-wide organization responsible for development of medical countermeasures, including vaccines against pandemics and emerging threats. Some of the prior roles she's held include that she was the Paul O'Neill Professor of Policy Analysis at RAND, where she started and led public health preparedness programs. And she was at RAND's Center for Population Health and Health Disparities. She was also a professor of medicine at the University of Minnesota and a medical advisor to the Commissioner of the Minnesota Department of Health. She was also Principal Deputy Assistant Secretary for Health at the U.S. Department of Health and Human Services. She received her BA and her medical degree from the University of Pennsylvania and did her residency in public health training at UCLA. She's a recipient of numerous awards and is a member of the National Academy of Medicine. Without further ado, I'm honored to introduce Dr. Nicole Lurie.
Thank you so much, Jeff, and it is absolutely an honor to be here. But thank you for that very generous introduction, which I have to say is probably longer than my whole talk. But I want to have the opportunity, as Jeff mentioned, to talk to you today about leadership in crisis and some lessons, I think, for the kidney community, as well as communities overall. And I think I'll just start by saying that in truth, crises can bring out the very best in people. Good response is built on the back of strong day-to-day systems. Nothing ever follows the playbook. You know, I think Winston Churchill said that even the best of plans don't survive first contact with the enemy. But I would maintain, if you just use the 80-20 rule, that if you do these core functions really well, you've got the mental space and agility to adapt to new situations. And finally, something I say all the time, never let a good crisis go to waste. And so I'm going to talk about these three things, I think, as we talk about leadership and what we have learned so far in this COVID outbreak. First thing I'll say is leadership can come from many, many places. We obviously often think about leaders as elected officials. Often we see incredible local and community leaders. Nationally in this COVID pandemic, we've seen terrific leadership come from governors. We've seen it come from mayors. We've seen it come from the clinical community, doctors and nurses. And we've seen amazing leadership come from local community leaders and other sorts of people. So, you know, when people ask me about this all the time, yeah, having authority is helpful, but it's not essential. You know, just before we all got on the screen together with all of you, I was remarking about the fact that I first had the opportunity to meet Dr. Silversweig when the American Society of Nephrology decided to form this emergency preparedness committee following Hurricane Maria to start to figure out, well, what could they do to do a better job helping the kidney community of providers and patients during disasters. And we started building a little bit of a day-to-day system, I would guess, but he has really stepped up and taken an incredible leadership role, both across New York and nationally, as we've watched people deal with the many challenges related to COVID. And some of the things that I think are really essentials for good leadership are things that he and I think many of the other people on this panel really embody. The first thing is you got to have a good handle on what's going on. In emergency preparedness, we call this situational awareness. But it might be about the epidemiology of disease. It might be about the supplies in your facility. It might be what your patient community is telling you, or what your neighborhood is, what's going on in your neighborhood. And it's great to have that situational awareness, all that information about what's going on. It's not much good if you don't share it with other people, or if other people don't share it with you. So information sharing for all the kinds of people involved and who have to take action is a really key attribute of good leadership. Good leaders elicit multiple viewpoints, and I would say that in dealing with crises, my own experience has been that it is incredibly difficult to get people to express views when they're under pressure. And everybody sort of seems to coalesce around this thing that we would call groupthink. And so having multiple kinds of points of views at the table is really, really important. And that's what part of the reason I'm so thrilled that even this panel includes nephrologists, nephrology nurses, representatives of the patient community, nephrology techs, and then people from national organizations. You have to have multiple points of view to avoid that groupthink. And you've always got to have at the table with you the people at the other end of this that are most affected by whatever crisis it is. A good leader is then able to come up with and galvanize people around a plan of action that a group might put together. It ensures that the plan actually gets executed and gets done, and is responsible for good communication, not only within that team, but out to the public in general, and to people at all levels dealing with a crisis. So just some overall essentials that I think are worth highlighting as you think about the leadership at all the levels we haven't seen it at this level of the crisis. I want to focus in a little bit on this issue about strong day-to-day systems and what we learned from them. And Jeff asked me to sort of talk a little bit about how the system is supposed to work. And so basically all crises and all disasters are really local. And I'll talk from the healthcare system level that every healthcare facility, hospital, nursing home, dialysis facility, whatever, needs to have its own plan, and its own what we call incident command system. And that facility just doesn't exist in isolation, any of your hospitals, any of your dialysis facilities. But in most communities, you are part of a healthcare coalition, which is an entity that has formed either under state or local public health jurisdiction to bring everybody together, particularly to plan. So there's community-wide visibility, and in a response, there is really good sharing of information. So I have very vivid memories, for example, of visiting, a hospital after the H1N1 pandemic and listening to all the ICU docs talk to me about how they were down to their last ventilator. They didn't know what they were going to do. And I would say, well, what was going on across town? And they would give me this blank stare. What do you mean? Well, were there ventilators across town? The Healthcare Coalition is supposed to help with that and sort that out. And I think you all might want to ask yourselves about how did your Healthcare Coalition do during this crisis. There's a lot of intense competition in the healthcare marketplace and healthcare resources. We often view the Healthcare Coalition as a place where co-opetition can take place. There's some things you just don't compete about, and that's really when people's lives are at stake when they're in a crisis. Emergency operations centers in all of these facilities form the basis of the strong day-to-day systems as well. There should be a hospital incident command system and emergency operations center in each of your hospitals in New York, and hopefully something similar in your dialysis facilities and nursing homes. They operate at a facility level, and as I mentioned, through the Healthcare Coalition at a jurisdictional level. And what is supposed to happen is when, in this case, a hospital or any kind of facility is struggling with personnel, with supplies, with surge, with patient overload, with any of these things. They need to be able to ask for help, and they do that first to the jurisdictional level, which would be the New York City Emergency Operations Center in your case. And if that jurisdictional level, which is also responsible then for situational awareness, let's say across New York City, if that jurisdictional level is overwhelmed, then it needs to ask the state for help. New York City is a funny example here, because New York City kind of functions a little bit as its own state and has the ability to go directly to the federal government for help. And so for health and health care, this is all handled in federal speak under what is called Emergency Support Function 8, which is healthcare. This would be to the Assistant Secretary for Preparedness and Response at HHS, which was my old job. And I would expect to get a call or an email from the Emergency Operations Center in New York City saying, hey, we've got this kind of trouble. Can you help us? There might then be a formal request for help. And with that formal request, there would be an evaluation of the request, the federal resources available, and usually some kind of help. So what are the federal roles and responsibilities in this? Well, they're obviously to fund the whole day-to-day system to make it work. And so they fund through a variety of grants, much of the emergency preparedness planning that goes on in any city. They provide information and situational awareness. So CDC does or should provide information about what's going on and work with your state and local health department to understand what's going on. And to the extent they have situational awareness from other jurisdictions that might be relevant, they share that as well. In a crisis, they might send support personnel. It might be the National Disaster Medical System, the Disaster Medical Assistance Teams, which I'm sure you're familiar with from other events. They might be able to bring material. They might be able to support your supply chain so that you actually don't have shortages, or so that you can get things quickly, like PPE or equipment or swabs for testing or any of those other things. One of the things that they are very much responsible for is the fair allocation of these resources that are under federal control. They should not be allocated according to who you happen to know, what political party you're in, how most of your voters vote, any of those things. And they should be allocated fairly across communities. And I know you're going to talk a little bit later about issues related to socioeconomic disadvantage and race and racism. They need to go where the burden is the highest. The federal government can also provide different kinds of emergency waivers. So for example, for you to be able to, in some sense, offload people coming to an emergency room to a tent or something like that outside. They ought to be able to let you have extra patients in your nursing home or hospital. They ought to say that there are certain kinds of requirements that we're not going to enforce during a crisis, such as drug co-pays or something like that. New York City, and I'm going to focus there because most of you are all in New York. New York City has had a ton of opportunities to strengthen its day-to-day systems, and we know that. And I've had the honor, I guess, of participating with New York City in one way or another in H1N1, through Superstorm Sandy, through Ebola, through Zika, and a little bit through COVID. And so there have been lots and lots of different opportunities to strengthen day-to-day systems there. And in truth, most of them are really pretty good. There are good surge plans for what would happen. There's been a huge amount of pandemic influenza planning, which has been relevant for COVID. There's been workforce analysis. There's a lot of evacuation planning, and you've all had a lot of experience now with evacuation. Through Ebola, there's been much improved infection control practices in hospitals and emergency departments. There's planning for mass countermeasure distribution and mass vaccination, which I hope will come in really handy once we have a vaccine. And the New York City Department of Health has really been a leader recently in focusing on equity, and I've really appreciated that. I've also observed, at least during the time I was Assistant Secretary, that there have been remaining challenges after each event. And many of these, I think, came to haunt us a little bit during COVID. There are 2 or 3 city-level healthcare coalition systems, and they're not sufficiently integrated in my mind. So the Greater New York Hospital Association runs one, Health and Hospitals Corporation runs another, the VA to some extent runs another. They don't all come together. It seems that both in the day-to-day planning part and for emergency response, the inputs, particularly from the public side and the private side, don't do very well together. And what that means is that the Emergency Operations Center could think that everything is fine based on the public hospital system when it's not, or vice versa. In addition, there's still incomplete integration of nursing homes and dialysis facilities into the planning, into the visibility, into the way the whole system works, and that still needs some work. I think one of the things I've continued to observe, and observed it again through COVID, is that at an individual facility level, whether it's a dialysis facility or a hospital, whoever's in charge of managing things for that institution isn't always sure who to call when they get into trouble. Who is it that I call at the Emergency Operations Center? How do I get in touch with them? How does the system work? And I appreciate that people turn over all the time, but I think that's something that we can all do better at. And so at the end of the day, better preparedness and response is going to require a better day-to-day system. And in between the kinds of events like COVID or Superstorm Sandy, we just got to practice and we got to train. And it's kind of a pain in the neck and we all hate doing it. But I can't tell you the number of people who stopped me in airports, the number of doctors and said, you know, I was so angry with you because you made us do this drill and it took time away from patient care and all this stuff. You know, but then a tornado hit our hospital and I'm so glad you made us do this. So I'm just going to leave that thought with you. Nothing follows the playbook. And so there's been a playbook for things like a World Trade Center attack. There's now a playbook for superstorms or hurricanes. There are plans for all kinds of events in New York City. And in fact, there's been a huge amount of planning for how the dialysis community in particular is going to deal with hurricane storms, power outages, all those sorts of things. A lot of planning around the country for earthquakes, for which thankfully New York City is not too prone. But I think COVID challenged the kidney community to think about other things that it hadn't thought about through many of these other disasters. One of them, obviously, was infection control and protection in dialysis facilities, because people infected with COVID couldn't not go to dialysis, and we needed really to think about how those people, how the patients and the staff were going to be protected. And also, how would it be that we would manage acute kidney injury on a really large scale outside of something like a crush injury setting, like an earthquake or something like that? I think it was a little bit out of the scope of imagination that part of the surge in hospitals would lead to a major surge in acute kidney injury and acute dialysis needs. However, the response really was built on all of the prior planning for all the other events, the kinds of pre-existing relationships that exist, and really strong communications within the kidney community. And I think people participating in the symposium are an example of that pre-existing set of relationships and the pre-existing communications that enable the response to be as strong as it was. And then finally, leadership comes from lots of different places, and it comes from everywhere. So I commented about Jeff's leadership, which I think has been really important. There's been tremendous renal leadership, as far as I could see, at all of the different hospitals and facilities across the region. Nationally, the nurses associations have been phenomenal. The patient community has been phenomenal in advocacy for all kinds of things, such as participation in vaccine trials, that I don't think was really on anybody's radar screen before. Leaders who you didn't even know they were there just stepped up and did what they needed to do and mobilize and galvanize people. There have been, obviously, lots of challenges and some strengths. So obviously, we don't have a national COVID response plan yet. We don't yet have national level guidance and we don't yet have national level a clear and consistent communication. And that has caused a ton of confusion. I think it's fair to say in New York, the governor really stepped up and worked very hard to do that. And at a facility level, I think there's been good work. At a federal level, a few of the day-to-day career staff really engage in kidney issues. And in this situation, once the nephrology community reached out for help, they were incredibly responsive. Whether it was with guidance and information about what to do with PPE and how to manage patients in dialysis facilities, or with some of the other problem solving. So I got involved in a little bit of this with Jeff, largely because of all the challenges around the dialysis facilities around the country. But then with this situation in New York City, mostly over Easter weekend, which I think for me was really interesting and exemplary of how things did and didn't work. And so for me, it actually started with a call from a family friend who is a nephrologist in New York who said, hey, we're having a huge amount of trouble getting dialysate at our hospital. Can you help? I don't know who to call. I didn't really know what to do, so I called Jeff. And Jeff said, oh yeah, we're having this problem here too. We got the two of them connected. Before I knew it, Jeff had thankfully called around all of New York City and found out that this was actually a pretty significant supply chain issue across New York City. He was terrific about convening everybody involved. But it's fair to say that there was really poor federal visibility and local visibility about this critical aspect of the supply chain that nobody had really thought about before. It wasn't clear who was supposed to call the Emergency Operations Center, and once it happened, they weren't also sure what they were supposed to do about it. And fortunately, with the help of ASN, Jeff and others were able to get the federal government involved. But if I think about some of the challenges at the federal level, they were really poor visibility of what was going on. Same with the Emergency Operations Center. At the local level, there were a lot of delays in getting in touch with one another. It's easy to think that a problem's just your own. And then of sort of getting together and letting people know that there were problems. But as I said, partly because of the strong day-to-day system and relationship you had, there was great emergent leadership, really good ad hoc problem solving, whether it was sharing recipes for how to make dialysate or how to work with the federal government to help them, to get them to help solve the problem. And a lot of creativity involved, which ultimately led, I think, to a great resolution. So the last thing I'll just leave you with is what I want to say: never let a good crisis go to waste. So some really good things I think are coming from this. Nationally, ASN is serving as an increasingly one-stop shop for HHS with regard to the kidney community needs in disaster. You might really want to think for yourselves about what you want that to look like regionally. I think that the local level collaboration across the community has really been strengthened from this, as has been the national level community. There is still, however, really bifurcated planning and a response system in New York City. And for my own self, having dealt with it in H1N1, having dealt with it in Superstorm Sandy, having dealt with it in Ebola, and then having watched it from afar now, it needs to be fixed. And all of you on this call need to step up, I think, and really demand that your city structures function better for everybody, not just part of the city. So how do you prevent this crisis from going to waste? How do you all want to organize? How do you influence the system around you? How do you bring everybody into this? The nursing community, the patient community, your schools, every part of the community. And as I said before this call, how do we start to envision now what we want the world to look like on the other end of this? And how do we start to create that now? I think that conferences like this that start to ask ourselves these questions about what happened and what do we learn from that are a really great start. I'm going to leave you with one other thought, which is we all know we're pretty close to an election. We all know that kidney patients are especially vulnerable when it comes to getting COVID. I hope you've all thought about how you're going to support your patients in voting, whether it's encouraging them to vote absentee, to have a plan for vote, but to make their voting as safe as possible and as participatory as possible. Thanks so much for the opportunity to talk to you.